Hi there, it's KMC here. You know, I've been hearing so much lately from doctors who, be it right or wrong, are thinking about ways that they don't have to bill Medicare or could be doing a service that's more cash-based than the required CMT code. And so I thought it might be an interesting help desk topic to chat a little bit about the difference between a CMT and something like 97140 manual therapy that people are trying to use. So first of all, let me be clear. There's never really a great time to just simply say, because these are Medicare patients, I'm going to do this differently. Um, I work with doctors sometimes that say, I'll only do an activator on a Medicare patient. That's my personal feeling and philosophy. That I have no problem with that, but an activator is a CMT. So under these circumstances, we have to think broadly and we have to think about the things that we have kind of as a philosophy of our practice, but also being good stewards of using proper coding and all of those things. So we all know when a CMT should be provided, when there is a subluxation that needs to be corrected, when the condition is appropriate to that. And then when we talk about 97140, they really are more germane to the muscle therapies. Now, it gets a little confusing because one of the definitions of 97140 includes joint mobilization. Joint mobilization specifically is something that PTs really do more so than anybody else. There might be occasions when myofascial release or trigger point therapy or joint mobilization is more appropriate for a patient as the primary service that you do. But it should never be weighed out as a way to get around having to bill Medicare or bill insurance. So understanding what this is all about, I want to just give you a couple of high points to think about. And one of them is the diagnosis. If you're going to be doing manual therapy, one would expect to see, particularly in the area of the muscle work, that there would be a diagnosis or condition that would benefit from manual therapy. And it's a logical explanation as to why you chose that, perhaps why you chose it instead of the CMT. Your treatment plan should be very clear. The functional goals should be relative to that particular service. Include your frequency and duration, include the muscle groups to be included, etc. Now, if you're trying to do mobilization, that's a whole other conversation, isn't it? The exam that you do should point specifically to the areas of tenderness, hyper or hypotonicity, muscle fibers, range of motion, things that would directly benefit from the diagnosis, obviously, that you've chosen, then benefit from the treatment that you're recommending. When you are doing the service on a routine visit basis after that initial evaluation and treatment plan, then you want to be sure the technique you're using, the service you're using, the area that is being treated is all included. And then, of course, when you're billing, make sure those diagnosis pointers are being attached to the correct service so that that muscle-related code or the reason for which you're doing joint mobilization can absolutely be connected to that specific diagnosis. And if you're electing to do both of these at the same time, which sometimes people do, remember that it's a little bit of a dogfight. You're going to have to think about, do I use the X modifiers? Do I use the 59 modifier? Are they in separate or non-contiguous body regions according to the payer's different rules and regulations? If you are a KMC University member, I urge you to go and review the information not only on those modifiers, but also the information in our documentation and coding training that specifically talks about documentation and coding of muscle therapies. Be a good egg. Don't try to get around billing Medicare using 97140. But when you do it, make sure that you're documenting it well.